I'm just going to give this just a few more seconds in case it takes a little while for people to actually come into the room, but I think that we are live. Hi, everybody. My name's Nell Montgomery, and I'm the Chief Executive at Psychiatry UK. And I want to wish you all a big welcome to this, our first patient webinar. The first thing I would say is please bear with us. This is the first of these, and I think we're expecting a few hundred people. So it's a learning experience for us. If we have any tech issues, I apologise in advance. So who are Psychiatry UK? We were actually established back in 2012 by my brother, Andy Montgomery, who was an NHS consultant psychiatrist. And most of what we do is ADHD and autism assessments for the NHS through what is called Right to Choose, that many of you will probably have found us through. And we are the biggest provider in the UK for the NHS, so we're really proud of that. Now, the reason we're doing this is we understand how difficult it is for you all to have these long waits, both for assessments and then if you get diagnosed, waiting for medication. We recently opened a contact centre, and I had the pleasure of going and listening in to some of our patient support staff talking to patients calling in. And it was quite a profound day. Listening to contact centre staff having to tell people how long they were going to have to wait. And it really galvanised us into action that we need to do a better job supporting all of you while you're waiting. So that's why we've set this up, and hopefully you'll get something out of it. We get told often that while patients are waiting, they feel like they've been forgotten. Well, you haven't been forgotten. We're here, and hopefully you're going to hear some useful things from some of my team this evening. So just to introduce who you're going to be hearing from, you're going to hear from Sam Spavin. She is one of our psychiatrists. She's a doctor. She's the sort of person who does assessments for Psychiatry UK. You're also going to hear from David Harvey. He's the medication man. If you get to the stage of being prescribed medication, he leads our amazing team of prescribers. And Bev Nolka, I was trying to work out, like, how do I introduce her? She is basically a champion of neurodiverse people, coach and advocate. So I'm sure you're going to learn a lot from her. So I'll hand over now to David, who's going to tell you about what we're going to do this evening.
Hi everyone, it's really nice to meet you all, although I realise that I can't actually see you all. If you ask me, probably one of my biggest fears is to talk to a large bunch of people, but if you give me a guitar and let me on a stage, I'm normally quite confident. So we're going to start off anyway, going through just some meeting guidance, and it's just to sort of set some expectations really. About the webinar, about the ways of working, and just why we've done things. So in order to help everyone get the most out of today's webinar, we've made sure that the microphones are muted, and that's really to reduce background noise. We've switched cameras off, and attendee names are hidden to maintain privacy. If you use the chat function to submit questions or share reflections at any time, I think we were going to have the QA panel open, but we've made a decision to close that. So the chat function there, I believe, is what we're using this time. All questions, they should be anonymous. And that's to protect privacy. Upvoting reactions have been switched off, and that's to maintain privacy. And remember, in your interactions on the chat is just to be respectful and considerate of all speakers and all participants. When we're speaking, I don't know if you know this, but there's lots of things that beep up and flash up in our faces from the chat. So I've muted it, but it's just to let you know that these things do crop up for a lot of speakers. And if we can just remind you just to avoid sharing any personal identifiable information in your questions, that would really help. if you're experiencing any technical issues, please post in the QA chat. So what we're going to do for this webinar is we're going to look at what is ADHD, and we've got Dr. Sam Spavin, who's going to start us off by going through in a little bit of detail what actually is ADHD. And we've also got Bev, who's going to look at talk about some things at the end around Q&As, and I think there's three hot top tips potentially. I'm also going to go through what I think is a really important thing for everyone to take away if they are waiting for medication, and that's the eligibility criteria to go into titration, because it's really important that this gets right, that people get this right, because at times we are unable to treat people because of various things, and that can really not land very well for some people. Also, I think it's worth noting, I believe a lot of people here have already had their assessment, but at times we are unable to diagnose people perhaps how they've expected. And it's just a note to say about that some people don't get a diagnosis. So there's sort of managing expectations about coming into Psychiatry UK and about getting your assessment and then going into onto what is a waiting list at the moment for meds. So anyway, without further ado, over to Sam.
Hi everyone, as you now know, I'm Sam Spavin. I'm the clinical lead for ADHD and one of the consultants who completes the assessments. Hopefully I'm not going to rush through the slides too much, but there is quite a lot I wanted to cover, so it may be afterwards that you do have questions and we can absolutely answer those for you. So ADHD is a neurodevelopmental condition. It's highly heritable. What that means is that quite often, if you get the diagnosis of ADHD, you might look back and you might see other family members who've got ADHD or another neurodiversity. It's really interesting when you look back into your family history, because you'll often find somebody who has a neurodevelopmental condition. It affects at least 5% of children, and 3 to 4% of adults, which really demonstrates that it is a lifelong condition. That means that quite often, if you've not had your assessment, you will find that what we will be doing is we will be asking you questions about your childhood experience, and whether you struggled with symptoms that could be related to ADHD at that, in early childhood before the age of 12. And that's really important. It's an important part of the criteria that those difficulties have to have started early, not developed later in life. The main symptoms of ADHD are inattention and then hyperactivity and impulsivity. And when you look at the criteria for ADHD, there's actually 9 symptoms of inattention, 9 symptoms of hyperactivity and impulsivity. And actually, you can have a combination of both. So really, everybody with ADHD can present quite differently. The other thing that is really important to acknowledge is that there are quite a lot of shared symptoms of ADHD with other comorbidities. So we really got, when we're assessing people, we've got to be thinking about differential diagnoses as well. It's really important that we're, when we're assessing people, that we're looking into what are the symptoms that people are experiencing and what are the root causes of that, because then that will help us work out whether you've got ADHD or actually are your symptoms that of a different condition, for example, autism, personality disorders like emotionally unstable personality disorder, depression, post-traumatic stress disorder, substance misuse, and many more, including physical health problems. So it really is not a tick box exercise. The other thing that's useful to acknowledge is the fact that we know that a lot of people with ADHD also suffer from other comorbidities. And the diagram that you see mentions quite a few of those comorbidities, but I think it's useful to recognise that we know that there's a high proportion of people who struggle with substance misuse who have ADHD, a high proportion of people who have anxiety and depression, people who suffer from binge eating disorder, and those who have sleep problems, as well as other difficulties. Just looking to a few different aspects of, kind of some of the comorbidities or specific issues related to ADHD. One is about substance misuse, and I've just mentioned it before that, up to 40% of people with ADHD can struggle with substance misuse. I think one of the thoughts is that that could be related to the fact that people are self-medicating as a way to try and support their ADHD symptoms. We know that up to 50% of adolescents with ADHD struggle with substance misuse, and the opposite, up to 40% of adolescents with substance misuse have ADHD. We know that treating ADHD can reduce and delay the onset of substance misuse. And there has been quite a large study that actually has shown that managing ADHD can be protective against substance misuse. The next area I wanted to talk about in a bit more detail was ADHD, and that is when you have a combination of autism and ADHD. And Autistica, which is a large charity, did some research on this and found that 3 in 10 autistic individuals also had ADHD. So there's quite an overlap. And interestingly, you can see from this diagram that there's also quite a lot of shared symptoms. So again, it makes it really, when you're diagnosing, it's really important to firstly look at what is the root cause of people's symptoms, so you can differentiate what symptom you have from autism, what you have from ADHD, but also just acknowledge that you can get both from both conditions. What we have found is that quite often when we're looking at treatment, the people who have both conditions can have a slightly different response to treatment. It doesn't mean it doesn't work. It can still be effective, but we do find that this group of people could be more sensitive to medication, and sometimes they don't like the response to the medication. So for example, it might actually treat their ADHD, but that might then mean that their autistic features are more dominant, and that can be difficult. So really, I think when we're looking at medication, the best thing to do is consider medication as a trial and see what the effects are. Do you find benefit from medication or do you not? Next area I wanted to speak about was the gender variation, and this is quite topical. We know that boys and men have a higher diagnostic rate than girls and women. The ratio is around 3 to 1, 4 to 1. And the theory around that is that women can go undiagnosed. And really that's thought to be because they can present differently. So some of their difficulties are more internal. So perhaps they're less identifiable. It's going to be less about the naughty schoolboy, which is this, old stereotype. And it might more be that some of the women with ADHD might present with more the psychological distress. Equally, it doesn't mean that women have to present that way. You know, as I said, everybody with ADHD is different. Because the intensity of depressive features in girls with ADHD tends to be higher, and this can have an earlier onset. So sometimes having this difficulty with depression and anxiety can actually kind of delay the diagnosis of ADHD. Another area of interest for many of us is ADHD and menopause. We often, when we're assessing people, see people of, you know, in their 40s and 50s who've really only just started thinking about ADHD. And it may be, for example, that yes, they had some difficulties in life, but they had coping strategies that they could manage. You know, life wasn't too difficult, or certainly it wasn't, impairment wasn't necessarily in all areas of life. And then you reach the perimenopausal period and your symptoms of ADHD can be much more intense, or, you know, exacerbated by the perimenopause. And that's thought to be because in the perimenopause, you've got changes in the estrogen level, and the decline in estrogen affects the dopamine regulation, which is thought to be in part related to the symptoms of ADHD, the worsening cognition and emotional control. And I think it's really important to kind of work with your GP if you're in this kind of age bracket. So I guess, you know, why do we treat ADHD? And before I get on to the next slide, actually, I think it's important to say, and I haven't got a slide on this, is management of ADHD is not just by medication. Medication is a really helpful tool, and in adults it is a first line treatment, but actually there are lots of other ways you can manage ADHD. There's holistic treatments, which they sound really basic, but actually it's difficult to get right, and that is, you know, ensuring you have a good night's sleep, eating well, exercising, looking at psychological techniques, looking at work adjustments, university adjustments, those kind of things. And when you are assessed by us, we can provide you with written information on holistic management of ADHD. But I'm now going to talk more about the medication side of things. So the reason we treat ADHD is we know untreated ADHD can result in poor academic outcomes and poor job performance. We know that there is a higher risk of accidents and injuries in those with untreated ADHD. We know that there's higher rates of depression and anxiety and substance misuse. And we also know that untreated ADHD can affect relationships and social connections. So when we're thinking about medication for ADHD, there's two main treatments that we consider. There's the first line treatment, which is stimulant based. And when we're talking about stimulants, we're talking about methylphenidate and lisdexamfetamine. Both of them have got loads of fancy names attached to them. So methylphenidate, for example, can be known as Zagotin, Zedidate, Concerta, Delmasart, Equisim, many more. Lisdexamfetamine is often referred to Elvans. Stimulants work by increasing the dopamine in your brain, which affects your reward center. That should improve your ability to concentrate, do tasks, and it can improve emotional dysregulation. It's one of the most effective treatments there is. So it's actually got a response rate of around 70 to 80%, which is really big. It does mean that 20 to 30% of people aren't going to respond to medication, or they're not going to tolerate it. The second line treatment is called atomoxetine. This works differently than a stimulant. It's actually a selective noradrenaline reuptake inhibitor. So basically what that means is it changes the amount of noradrenaline in the brain. And this is something that we would tend to use if we can't use a stimulant, or if a stimulant hasn't worked. There are side effects. There are side effects to every medication. If you look at paracetamol, there's going to be a long list of potential side effects. But with our medication, there are side effects, and it's very easy to research them. We can provide you with written information about the medication as well. For stimulants, so those are methylphenidate and lisdexamfetamine, your blood pressure and pulse can be affected, and that's why we look at what your baseline blood pressure and pulse is, and it's why we monitor your blood pressure and pulse during our titration period. It can reduce your appetite. So sometimes it's about changing the times you eat, and sometimes it's making sure you eat a healthy diet no matter what. You can commonly get headaches. Sometimes they're worse at the start of treatment, and they can be supported by making sure you drink and eat well. You can get other symptoms like dry mouth, and sometimes you can get things like irritability, and it can make you feel more anxious. That can be a dose effect, because we don't know what dose you need. You are an individual. So in the titration period, we're trying different doses, and it may be, for example, that we prescribe too much for you, and you might notice that you feel more agitated, or you might get palpitations, and you might feel more anxious, and that's fine. This is part of titration. You let us know that you are having side effects to the medication, and we look at what you were like on the dose before, and assuming that was effective, we just simply reduce your dose down. So in terms of atomoxetine, it's actually got quite a similar side effect profile, although for different reasons. So it can still affect your blood pressure and pulse, so we still monitor for that. It can affect your appetite, although you might either get reduced appetite or sometimes increased appetite. It can affect your sleep. In this case, it can sometimes make your sleep worse, or you can be sedated. You can still get dry mouth and headaches. One that's slightly different in atomoxetine compared to stimulants is there is a possibility of an increased risk of suicidal thoughts. So obviously, if you start the medication and you do feel suicidal, you let us know, because it may well be the medication. It's also worth keeping an eye on people's liver function. In very uncommon cases, it can affect the liver. Before I talk, actually, no, I'll talk about the patient journey now. So for those of you who have just been referred and you're waiting for your assessment, this is what your journey is going to look like under Psychiatry UK. So you have been referred under Right to Choose. You will be sent some paperwork to complete. There'll be a few different forms, and I think sometimes it's easy to feel overwhelmed by this, but take it one at a time. They are really important, and they're really helpful in terms of giving us as much information as possible in order to work out if you have ADHD or not. So there's a self-report where you give examples of various different difficulties you may have experienced. There's an informant report, and this is quite an important one, because this is where we can get collateral information to show that you may have struggled with symptoms of ADHD from an early age. So we want somebody who has known you since childhood to complete these forms. There's a report scale, which is a tick box, and that kind of demonstrates how severe, or what areas you struggle in. And then there's a health form, which mainly concentrates on your heart, to see if you have any difficulties or if there's any family history of heart problems. Once you've completed those forms, you will then be sent a link, and there you can make an appointment, and there'll be lots of appointments available to different consultants, and really you look at that and see which consultant you want, what time of day you want, and you choose your appointment time. The assessment itself is virtual, so that means it's like this, it's on the internet, you can have it, you can do it at home, but it's done via Teams. It takes around 50 to 60 minutes. It can be more than that. As I said before, the more information that we get in the forms really supports us to do a good assessment. Hopefully, at the end of the assessment, we can say whether you do or you don't have ADHD. And I think, just referring to what David said earlier, not everybody will come out with a diagnosis of ADHD. This is very much for an assessment. But hopefully, if you don't have a diagnosis of ADHD, we can either signpost you in the right direction, but we can still give people support on how to manage their ADHD-like traits. Afterwards, we can talk to you about whether or not you just want holistic management of ADHD, or whether we refer you for treatment. And if you want medication, we refer you to the treatment waiting list. The best way to know how long the waiting list is to check with the website. The website will give you up-to-date information. We are very transparent about the wait, and it will change. We're always looking at ways to reduce the wait time. What I didn't mention earlier, which I was meant to, is tell you a bit about the actual titration experience. When you're at the top of the waiting list, you'll be sent a message which will ask you to fill out 2 more forms, a pre-titration form and a blood pressure, pulse and weight, which David will talk a bit more about. Then, assuming that there is no concerns identified on that, you'll be sent your treatment plan. And that will tell you what medication you're going to take at each week. And we go 4 weeks at a time. And that is really helpful to look at the treatment plan instead of the box of medication that you get. You will also, we start off with the lowest dose possible, and usually speaking, for the first 3 to 4 weeks, we increase the medication on a weekly basis. You complete a monitoring form every 2 weeks, and that ensures that we're prescribing safely by monitoring your blood pressure, pulse and weight. It's a way of finding out if you have any side effects to the medication that we need to consider, but also it helps us look at what the benefits of the treatment are. So then that means for the next month, we know what to prescribe to you, and we know everything is going in the right direction. This is for about 12 to 14 weeks on average. And at the end of the titration, assuming medication has been helpful for you, you would have something called an end of titration review, which will be with your prescriber, where you'll talk about your experience and be given information as to what happens afterwards. And at that point, assuming you continue the medication, we will ask for a shared care agreement with your GP. Like, GPs do not always accept the shared care agreements, and under right to choose, we can continue to prescribe for those who've got declined shared care agreement. It's also useful to know that we work with secondary services. So it's important that you inform us of any other mental health services and specialists that you're under, because then we can communicate with them at the same time to give them updates. I think it's helpful because unfortunately in the assessment process, we look at the negative parts of ADHD, we've got to be able to demonstrate that there is impairment. So my experience is, sometimes it can be a little bit depressing because a lot of the questions are looking about what you're struggling with. But actually having ADHD is not always a negative. There are actually quite a lot of strengths with ADHD. For example, we find that a lot of people with ADHD are really creative. Their ability to hyper-focus can be a huge strength. They can be great at problem solving, thinking on their feet, being reactive in crisis. They can be adaptable to lots of different surroundings, situations, and they can think outside the box. And we all need people who think outside the box. Sometimes it's just about reframing the negatives. So, for example, hyperfocus, when you kind of go down that rabbit hole, that can be, passion and drive. And actually, in some forms of employment, those skills are amazing to have and they're really valued. Being distractible actually makes you much more curious and you're learning all the time and you're thinking differently. People who struggle with authority, maybe they've got the leadership potential, and they're going to inspire people to think differently and challenge the norms. Other people who are sensitive to criticism, maybe it's more they're empathic, and they will have a better understanding of other people's emotions. So really, people with ADHD should be understood, not judged. We know some days are heavy, really difficult. Others, you have really good days and you're going to feel really positive. Really, it's what we need to look at, what society needs to look at, is instead of thinking what's wrong, thinking what's happening and how can they be best supported. So, end of my talk. I'm now going to transfer you to David, who's going to talk a bit more about getting ready for titration.
Cheers, Sam, and I love the ending of that. It was really positive, so thank you so much. So, look, before starting ADHD medication, we just check a few things to keep you safe, make sure treatment works well, and this includes physical health, any other medication you take, and your mental well-being. And if something isn't ready yet, that's kind of okay, actually, because we'll explain what needs to change and how you can get there. So onto the physical health part of things. It's just to add that this is about the eligibility criteria and things to think about over the next whilst you are waiting to go into a position where you can have medication. So I really want you to just have a think about where you're at as I go through this and if anything needs to change so that you can give yourself the best opportunity to have successful change when it comes to treatment. So we check your blood pressure and heart rate because your ADHD medications can sometimes raise them. And I noticed in the chat there's some people pointing out that they've had their blood pressure monitors delivered, so it's good to hear that you've got them. Your blood pressure should be 149/90 or lower, and your pulse should be under 100 beats per minute. If these are high, we'll ask your GP to help manage them before starting treatment. We'll also look at your weight, and if your BMI is below 18.5, we'll talk to you about how to keep it stable because medication can affect your appetite. If you've had an eating disorder though, we'll agree on a safe weight range together. We'll also have a little look at your heart. So it's acknowledged that some medicines can affect your heart rhythm. And if you're on certain medications, we may ask for an ECG before starting ADHD treatment. So it's just to let you know that that may be a request from us. And that will actually mean that you'll have to go and actively go into a service, and we'll tell you which one to go and get your heart checked. And that's just a few simple leads on your chest. And we just want to make sure your heart is safe. And if you're something called a QTC reading, that Sam will probably be able to tell you about more than I will. And if that's higher than the safe limit, we'll work with your doctor to review your medicines around that. So other medicines, serotonin risk. ADHD medicines can interact with some antidepressants and other drugs. So if you're on more than 2 medicines that affect serotonin, we'll just need to review that first. And that's to avoid a rare but serious condition called serotonin syndrome. And we'll give you written information so you know what to look out for. Next slide, please, Sam. Okay, so substance misuse. So alcohol and drugs. Drugs like cannabis, cocaine, MDMA, ketamine, they can all feel good, but they can make ADHD medication unsafe. And we've got to do things safely, and any decision around alcohol and drug use is done with safety in mind, because we need to make sure that people are not coming to any harm in the medication that we prescribe them. If you use them regularly, we'll ask you to stop for 3 months before starting treatment. If you use cannabis occasionally, you'll need to stop before titration begins. But if you're prescribed medical cannabis, we'll check the THC level and make sure it's safe alongside ADHD medication. And it tends to have to be, I think, below 22%. Alcohol, drinking too much alcohol, it can affect your health, it can affect the medication. And if you drink more than the safe limit, which is 35 units a week for women or 50 for men, we'll ask you to reduce this first. And ideally, you need to keep it under 14 units a week. Okay. So just on your mental well-being. I'm a mental health nurse. I think mental health is the most important thing in the world. More important than your heart, probably, if you ask me, to be honest. If you've had a recent mental health crisis, if you're self-harmed, if you've had a hospital admission, we might need to wait until things are a bit more stable for you. But that's not us saying, no, we will not treat you. It's a case-by-case basis. We do things patient-centered. We take them one person at a time, and we listen to you without using blanket restrictions. So if you aren't having a great time, have an honest chat. That's what we want to do. And then we'll work things forward with you. It's about making sure that you're ready, that you feel supported. And if you had severe mental illness like psychosis or bipolar in the last 6 months, we might need a little bit of a longer period of stability before starting medication. But as I said, person by person basis, this is about you. It's about your individual approach. So starting ADHD medication, it's team effort. If something needs attention first, that's fine, and we'll help you get there. But it's just to say your safety and your well-being comes first. So all that I've shared with you is to make sure that you are kept safe. And that's all from me. So thanks for listening. So there we go. Healthy bodies, safe medication mix, stable well-being, the key. Avoid drugs, keep alcohol low. We're here to help you succeed. Thank you.
Okay, so we've got plenty of questions, trust me. I've made notes and we have lots of them. But you did suggest, David, that I might have a few tips for everyone. So I have prepared just a few more than 3 because it is Christmas. So I thought I'd be, Christmas present, a little bit general, be like an advent calendar, but sort of halfway through December. So I'm just going to share this very quickly. It should knock yours out automatically, Sam, I think. So I'm neurodivergent. So these are some ideas to support an ADHD brain. Now, these are tried and tested. I have tried them. Some of them have failed miserably, but some have worked quite well. So obviously pick and choose as we go along. So the first thing is to try and match tasks to your natural dopamine patterns. So notice what energizes you and build your sort of day around that. If it means getting up at 5 o'clock and, busting out some work and until 12, and then you have a bit of a break, and then you because you have a slump. We all get a slump, and then you want to do some work later on. If you can do that, it's about protecting that peak focus window. Breaking tasks down into dopamine friendly steps, so micro goals. We know that if we have huge goals, it's going to be so hard to get there. So breaking them down into tiny goals can really help us get there, and actually make sure you're rewarding yourself as well when you do get those tiny goals. Body doubling. If you've used FocusMate, I think you can go onto the website FocusMate and you can do some body doubling. I think it's something like £5 or £6 an hour, but you actually can sit there and make yourself accountable to someone else. That can be really helpful. Use your hyperfocus intentionally, not accidentally. So create hyperfocus zones. So make sure you have as minimal distractions as possible. We've seen in the chat today lots of distractions with the chat. I understand that, but when you're working, try and make sure you have the visual distractions are minimal. Working with your emotions, not against them. Now, we know that we can have that emotional variability. That's a nice way to put it, I think. The intensity, but it can be a strength when it's channeled into creativity, advocacy, or real meaningful work, and it can fire you up to get work done as well. So build your environment around your brain. So, using visual prompts, visual timers, you can see the time sort of going down. If someone says to me, I'll see you in 10 minutes in a meeting, I'm going to just still be working. So having a visual timer can really help as well. And, using curiosity as a real problem solving tool. So one of our executive functions is metacognition, something that we can be quite poor at, that reflective ability, but actually use it as a strategy to sort of help us think about what was happening with that behavior, what was underneath it, what can I do to improve it the next time, but also protect your energy. Rest is strategy, it's not a reward. ADHD brains need recovery, and they need that time from overstimulation. So honoring your rest really does help boost resilience. Another thing, now this might be a little bit out there, but I actually think that mind wandering can actually be really good for our metacognitive skills, and actually come out with your best ideas in the shower, or when you're out for a walk, or when you're just walking the dog, or even going to the shops. You get these little sparks, these little glimmers that come through, but actually plan those breaks throughout the day. This is another one that comes from Japan, and they are masters of productivity. They started off with the Trello board, if you've heard of Trello boards, and we'll come on to those very briefly in a minute. But Shisakanko simply means calling out, and it's been used since the early 20th century. And they use it, they've got the bullet trains in Japan that go extremely fast, so safety is paramount on the platforms. So one of the conductors, what they will do is they will actually point and call to shut the doors, to make sure that people stand clear. And they actually know, they did this study at the University of Waterloo in Canada, and it was found that speaking out loud helps really to embed the words into the long-term working memory, helps with the short-term working memory, one of our executive functions, which can be quite poor. And it's actually been dubbed the production effect. So it found that it really does help the brain learn and benefit from active involvement. So doing and calling, if I'm walking out of the office into the kitchen, I look absolutely peculiar, that even the dog looks at me weird and says, what's she doing? But I literally point and say, I'm going to the kitchen to get a glass of water. So it does really help saying it out loud. Another thing, you might have heard of this, is an ADHD launchpad. So it's finding somewhere in your home that you can put your bag, your wallet, your keys, and you put them all together. So on a Friday afternoon, I run a support group in my local area for families and adults with ADHD. And this is a picture of my door. And then to the right of that, I've got this sort of half moon table that someone was throwing out, and I managed to keep, and I use that as my launch pad. So when I'm going to have the group on a Friday, on a Monday, if I want to add things to my bag or onto that table, I know that I literally just grab everything off that table and go. I don't have to think, well, where is it, and start panicking and walking out the door and coming back in. I literally put everything there. Sometimes I'll put a bag there. I've got a whiteboard there. It's actually yellow, but I put notes on it, and that helps me to retain information and remember to take everything. So it saves coming back. Going on to the Kanban board, I told you there are a few more than 3. Sorry about this. We're going to get whizzed through them. Kanban board, if you've not used one, they're brilliant. You can use the Trello board on your computer, but a Kanban board is brilliant. Actually having one physically in your house. So when you're getting up and moving, that adrenaline's helping you to stimulate your dopamine, get that going up your vagus nerve into your brain, and you get work done. So you put all your to-do list in there. You then go and put one at a time into your progress column. When you've done it, it goes into your done column. By the end of the day, you've got all of these things in your completed column, and you know your brain's having a high five and saying, isn't that amazing? Look what you've done. This dopaminergic reaction is going off, and you're feeling fabulous. So there you go, a few quick tips there, and now we're going to go on to the Q&A, and we do have quite a lot, especially around medication, but what I'll do is I'll start with one here. Someone's said that actually this sort of stems on from what you were saying, Sam. They were diagnosed in the 4th throw of perimenopause, and HRT has been very helpful. So I think you'd agree that that was a good thing.
Yeah, absolutely. And I think it's about using all treatments available, isn't it? You know, so it's about managing things holistically, but also treating your comorbidities as well. So HRT can definitely be a huge bonus.
Brilliant. So another one around this, from when you were talking about the diagnostic criteria, you said that symptoms need to be visible from under 12 years of age, but then say they may not emerge until menopause. So it seems a bit of a tricky area to get through for people.
So I think what we mean is it may be, for example, in your early childhood, you may still be a star pupil. So you may still be passing, you know, getting great GCSE results, great A-level results. You might be the star of a sports day, and actually coping. However, when you look into the details, you still might be the child who is staring out of the window, doodling on your paperwork, doing your homework last minute. So you might be coping. You may not have any huge differences, but there is evidence of ADHD, and that's what we need to look for. So it may be that the difficulties and the impairment only come later, but the symptoms are still present early.
Thanks, Sam. Another one we've got here is does medication affect the positive things? For example, creativity. So I'm assuming what they're saying is, does it stifle that, or can it enhance?
I haven't been on medication, and I think the reality is it's a very individual experience. So there is certainly a group of people who talk about ADHD medication being the magic cure. From my experience, they are far and few in between. The majority of people find that medication helps in some areas of their ADHD, but not all of their ADHD. And I think my son, for example, is on ADHD medication. He doesn't like it. He doesn't like the feeling of concentrating. And I think he actually quite likes the fact that he can think differently and be quick to think and, you know, look at ideas in a different way. And I think by treating ADHD, you are improving people's concentration and ability to stay on topic. And that might be something that you appreciate or you don't. So I think you can get mixed effects.
Personally, I'm a proponent of medication. It really helps me, helps with my focus. It doesn't stifle my creativity. I think what it does for me, it helps me focus that creativity. It helps me sort of actually finish one thing, especially hobbies, which are predominantly poor. So we've got quite a few here around medication, so hold on to your hats. How do you manage patients where GP practices are not accepting right to choose shared care agreements for medication?
So at present, and I say at present because we all know that things in life change. So but at the moment, when we have what's called a declined share care agreement, we continue to prescribe the medication. And so that means you'll get your monthly prescriptions from us. So you need to be requesting us to prescribe each month. and as per usual, whether it's a share care or declined share care, we would do your annual reviews as well.
Brilliant, thank you. There was one here. Can you take PrEP and ADHD medication?
Yes.
Simple answer. Brilliant. Thanks, Sam. Is there any way you can access the medication quicker than 10 months from diagnosis? We've had quite a few around that, around timings.
And the right to choose, the reality is there is a wait list. There's a wait list in the majority of places that you're going to, that right to choose is available from. Obviously, if you get treatment privately, it's, you know, wherever you go privately, that's going to look differently.
Okay. Does the medication help you stop trying to self-medicate?
I think from many people's experience, yes. So I guess people think of it as, you know, you're getting that dopamine replacement, you're getting that hit. You don't need, sorry, you don't need that dopamine hit. So people don't need other treatments, and it also should reduce your impulsivity. So it can reduce your likelihood of kind of, you know, using things like cocaine and stuff.
Thanks, Sam. Is there any medication you cannot take whilst taking stimulants? For instance, I use Foster for asthma.
Inhalers, as far as I'm aware, pretty much all inhalers are absolutely fine. There are medications that you can't take with our treatment. One of the reasons when we're doing both our initial assessment and why we do the pre-titration forms is to look at what medication you're on to make sure it is safe for you to continue. As David said earlier, one of the things we look at is the treatments that increase your serotonin risk. And you can only be on 2 of those as well as our medication.
Thanks, Sam. Is there a come down off the medication?
People are unlikely to be dependent on it or withdraw from it. However, it's not uncommon when people describe things like afternoon crashes, and I think that is when the medication leaves your system, and people could feel, you know, tired, agitated during those times. And ideally, the way you want to manage that is ensure you're well hydrated, you've eaten well. Sometimes exercising around that time can be really helpful. Sometimes it's a case, get all the important things done when you've got the medication in your system, so then it doesn't matter if you haven't got the energy to do everything else in the evening.
Brilliant. What are the panel's thoughts on the recent announcement by the Health Minister ordering a review of mental health, ADHD and autism overdiagnosis?
Do you want me to take that one? Yeah.
You can do.
Yeah. We are firmly of the view that ADHD and autism are not overdiagnosed. We think that about 30% of the UK population who have ADHD have been diagnosed. There are still 70% of people who have yet to be diagnosed. And the ADHD task force, which was commissioned also by the government, was super clear when it came out about a month ago that ADHD in the UK is underdiagnosed and undertreated. And interestingly, the last sentence of the review statement said that they will be looking at the ADHD task force. So I think it's very hard for them to conclude it's overdiagnosed when another government party looking at the evidence said totally the opposite. So don't believe what the politicians tell you or you read in the newspaper.
Brilliant, thanks, Neil. Do you feel there needs to be a review of how ADHD and autism is assessed and diagnosed, such as combining the assessment process to rule out instead of rule in ADHD?
I think that's something that we have thought about and we will continue to think about. I think we've got clinicians who do both. So, you know, there's many clinicians who will assess for ADHD and autism. it's very difficult to do it in a one-off assessment because it's going to be long. So certainly if you've got ADHD, that is one, long assessment that could be unbearable for you. It's also, a lot of the questions that we ask can feel quite intrusive and difficult at times. So there is an advantage to having them separately. But we are reviewing how we're doing things and, always looking at best care. So it may be that we offer something different in the future, but at the moment they're both separate.
Thanks, Sam. Someone's mentioned about, and there were a couple of comments around the BMI. Someone's saying they're quite muscular, so their BMI is inaccurate, and someone else actually validated that comment as well.
I think BMI is a tool, and we like to think about it is a tool. We do take into account other factors. I think that when you've got a low BMI and other risk factors such as anorexia, then we've got to look at the whole picture. Equally, we know that there are people genetically who are going to be very, very slim and have always been of a low body weight. Taking that into account, we're still unlikely to start that group of people if their BMI is 13, because it's just so far away from the view of what normal is. But we are certainly flexible, and we've got various different ways of managing things and looking at things. As to high BMI, we're less, I guess, less concerned in some ways, but we would still talk about advantages and risks of treatment.
Brilliant. Someone's actually said, what if they don't want to take medication? They just want support after a diagnosis.
Absolutely fine. Nobody is going to push you to take medication. It is not an option for everybody. We would provide you with written information for management of ADHD, non-medical management of ADHD. At the moment, Psychiatry UK does not provide psychological support. And I think if you were to go to your GP and ask for psychological management of ADHD, they're likely to say it's not available. However, what is available is talking therapy for mental health. So you can still get treatment for anxiety, which is related to ADHD. It's about focusing it slightly differently. You can still get treatment for low self-esteem and low self-worth. One of the things that's really valuable is ADHD coaching, and that's available from Access to Work if you're in employment, and that's something that you can self-refer to. So there are other treatments out there.
Brilliant, thanks, Sam. How much research is there on taking ADHD medication whilst pregnant and breastfeeding?
It's one of those, it's a slightly tricky ground in that it's not ethical to do research on pregnant women or breastfeeding women. However, there is actually an increasing amount of data available now on people who have continued to take medication in pregnancy, and I think that's increasing all the time. And the general view is that it is a risk versus benefit decision. It's a very individual decision. What we won't at the moment do in Psychiatry UK is start ADHD medication on someone who is pregnant. However, if you are already stable on medication and keen to continue, we can absolutely support that. We will still give you information. We usually provide something called a bumps information, which is up-to-date research, so you can read the benefits and disadvantages of treatment and make an informed decision yourself as to whether you want to continue.
Thanks, Sam. Someone's asked if they legally do they legally need to inform their employer of their diagnosis?
I'm going to say no, but I don't know if anybody in the panel think differently. As far as I'm aware, no. You don't. You're not going to get any help from work if you don't let them know, though. It is something that employees should be able to provide support with. You can't be discriminated for it. But I don't believe it's legal to inform people. And that also goes with the DVLA as well. Because a lot of people think that they need to contact the DVLA if they get a diagnosis of ADHD, but actually you need to contact the DVLA if you think ADHD affects your safety in driving, but not if you are driving well without any concerns.
I think, can I just come in on that? So I think one of the really beautiful things that you see it nowadays is that this kind of the ADHD is getting more attention from employers, and it's being seen as more of a positive thing to know in order to support people in their workplace, because a lot of people that have ADHD can often find out about it once they start going through HR issues or start getting into trouble at work. So it might be worth thinking about whether it would be a benefit to you to let your employer know if they've got a really good attitude towards it, because then they'll look at supporting you, and that would be just awesome.
And also, I'd say learning from you as well,
Yeah.
learning from your lived experience, which is invaluable. Another question we've got here, is a woman's menopausal cycle taken into account during titration?
That's a good question.
Yes and no. In fact, actually, David and I were discussing that today. So we do know that there is various parts of women's health that affect ADHD, but can also, flexibility in treatment can make a difference. We do take it into account, and I think hopefully, we're going to think even more about it and publish more guidance on it in the future. But yes, the answer is yes, we do take it into account.
Brilliant, thanks, Sam. We've had a question come up about workplace adjustments, but I think that was a plan probably for another webinar. So yeah, in the feedback form that we've already put in the chat, if you've got any ideas around anything that you would like to hear about, that you'd like us to talk about with you, this is your time. Put it in there, and we will then collaborate and put some more things on for you. I think we've got time for one more question here. All the questions that we haven't managed to get to, do not worry, we are going to look at these, and I think we're going to be putting them in the next patient newsletter, which will be coming out at the beginning of Feb. So it'll give us time to collate them and really give some good solid answers. So don't worry, each one will be gone through. The last question we've got here is, does ADHD medication increase the likelihood of developing Parkinson's? I don't know if that's something that, I don't know if that was a good question to end on, or if that's I'll come back to you.
Mihaela might be able to help support this. As far as I'm aware, no. But Mihaela, do you think differently?
No, I'm not aware of any strong evidence in regard to that, but the data in regards to the impact on different conditions, of course, is still developing. So we can look more specifically into this, and we can provide them more up-to-date answer. But as far as I know, no, there is not a strong link here.
I think one of the things that is probably helpful to think about is the fact that whilst ADHD medication has been around for decades and decades, it has, for the majority of that time, been used to treat children, and then up until the last decade or treatment stopped. So actually we're still gaining lots of information on the use of treatment with adults.
Brilliant. Thanks, Sam. Thanks, Mihaela. So I think over to you, Nell, to finish our webinar this evening.
Thank you, Bev. I feel like we might need to enter Sam into mastermind with the specialist subject of ADHD. I think she could probably really do well, don't you? Fantastic job answering all those questions, Sam. Thank you to the panel, but thank you all of you patients out there who have given your time this evening, and also your trust. Thank you for trusting in Psychiatry UK, coming to us with your health issues. I would like to apologise for these long waits. Unfortunately, the combination of literally tens of thousands of people coming for assessments, some limits on NHS budgets, and us just not being able to get quite the capacity of particularly prescribers to get you your medication more quickly, but we're working really hard on trying to improve that. So bear with us, you're not alone. You have not been forgotten. If you have more questions, you can always call our contact centre. I think we'll post the number somewhere obvious for you to be able to find that. But thanks again, and look out for other webinars. This is just the first of a series. We've really enjoyed putting it on, so hopefully we can see some of you at another one in the future. And Merry Christmas. Thanks a lot. Bye-bye.
Cheers, guys.